absolutely different picture. And when I first time seen this in theater, I was thinking, oh my gosh, what is he going to do with that? So it's absolutely not the same picture as you've seen on the echo before. So there is coronary sinus. It's a surgical view. You can see the septum, ventricular septum here, with the common valve. And this is an atrium, common atrium in this case. When you start thinking about that and got some experience, you can distinguish where is leaflets and what's the name of that. And till end of that surgery, I can remember I thought probably it's the most elegant surgery I've ever seen in my life, because I really like what the surgeon did with the valve and how he did the repair. And I still think that it's a very elegant surgery, even now. So when you start systematize these structures, you can distinguish quite constant part of this valve. So it's surgical valve view as well. There is a normal tricuspid valve and mitral valve, and there is AVSD types. So you've got superior bridging leaflet, inferior bridging leaflet, and mural left and right part of that. And there is a septum you can see in the middle, ventricular septum. So I'd like to say a couple words about hemodynamic, about circulation, because I think it's fundamental for congenital cardiac surgery and cardiologists and surgeons, whoever is involved in this difficult specialty, complex specialty, to understand what's going on with hemodynamic. There is pictures from fetal circulation, just to start thinking how the circulation changing through all the periods after embryology. Because from my personal observation, when surgeon starts speaking about embryology, he is looking for excuses. And if he speaks about circulation and hemodynamics, he is looking for solutions. And in both cases, I think it's highly likely that repair doesn't work. But if we have a look into circulation and we can try to find solution and separate waves for the patient, because it's not straightforward sometimes when you've got borderline ventricles or borderline valves, what to choose. And this understanding can help us a lot. So in the fetal circulation, there is no much difference in terms of saturation pattern. You can see circled, it's a circulation, it's a saturation of the blood. You can see normal heart here and AVSD here. So the main difference is saturation in the right ventricle. It's a bit higher in case of AVSD. And what does it cause? So it causes overcirculation to the lungs. Although they don't work on full capacity during the fetal life. It's about only 10% of blood volume circulating through the lungs in fetal period. So, but it does increase blood flow through the lungs and return to the left ventricle. And there are two main causes of that. So first is proliferation of muscle layer in pulmonary vessels that can multiple the risk of pulmonary hypertension in childhood and adult life. And another thing, it's overloading of the left ventricle. overloading of the right ventricle subsequently, and we can get regurgitation on this common valve. And the main risk factor for fatal death is regurgitation and high drops. So if valve is not leaking, it's highly likely that fetus will survive till the birth. And if there is a significant leak, it's highly likely that not, because of development of high drops and stillbirth. So just after birth, circulation changing dramatically for the child. We've got newborn with fully expanded lungs and 100% circulation through that. And because of as well higher oxygen saturation in the right ventricle, we've got a bit of over circulation through the lungs, but due to newborn pulmonary vessel resistance, it's compensated and getting worse in infant period after months of time with dropping of PVR. So it's getting worse. You can see the pattern of saturation in the pulmonary artery can go up to 90%, and it will even more relax pulmonary vessels and allowed over circulation through that. So the main clinical feature of that is over circulation is overloading of the left ventricle, subsequent overloading of the right ventricle, dilatation of the common valve annulus, and regurgitation on this valve. So yeah, and this causes congestion heart failure in this group. So if they survive this heart failure, the pulmonary vessel resistance can go up as a development of pulmonary hypertension, and it can cause decrease in symptoms even because it reduced overloading of the ventricles, and common valve can go to normal size even. But it doesn't mean that patients are getting better, so they're getting their pulmonary hypertension developed. So clinical presentation, as you know, it's symptoms result from high pulmonary blood flow. It's pulmonary hypertension. It's various degree of AVV, atrioventricular valve regurgitation, and congestive heart failure with tachycardia, tachypnea, intercostal retraction, failure to strive, and all this stuff. That sometimes you can see, and patients even need admission to ICU for medical treatment. So medical treatment options, you can treat with them with furosemide, for example, with heart failure medication. You can do surgical repair. And sometimes it's difficult to choose what is better and what's the main reason for deterioration of the patient. Is it a chest infection, or it's overloading and overcirculation because of hemodynamics? So main surgical options is pulmonary. It's biventricular repair. Obviously, it's pulmonary artery bending as palliation or a stage repair or a stage 2 biventricular repair and univentricular repair. Everything depends on the balance of the ventricles and valve. And the main part of this is not a surgery. Surgery is very important, but I think the main part is to decide what way is right for the patient. And I really like this paper, and it helped me a lot during my practice back in my home country in Ukraine. It's echocardiographic definition of surgical decision making. It was published in Circulation in 2010, and it's a paper from 4 hospitals in Northern America. It's Toronto, CHOP, Cleveland, and Minnesota. So they probably, I'm pretty sure you have seen this article, but just to remind and to go through, because I haven't seen it's, I mean, commonly used in aldehyde. Probably it can help in some difficult, not obvious decision. So they distinguished balanced AVSD as, yes, the main part is they described atrioventricular valve index, that is a relation of left part area, so you can measure it on echo, to common atrioventricular valve area. So, and if you've got it between 0.4, 0.6, it means it's definitely balanced AVSD. And if it's less or more, so it means it's right dominant or left dominant AVSD. They've got about 300 patients overall, and they choose different options on the basis of this index. And you can see it's quite easy to decide when it's when it's balanced, and most patients went for biventricular repair in this group, and it's easy to decide when it's less than 0.2. It means it's definitely, almost definitely, univentricular repair with Glenn and Fontaine way. And the gray zone is really when it's in between balanced and unbalanced, and it's difficult to decide. And you can see that the mortality is the highest in this borderline group. So they got 300 patients, and most of them were balanced, and you've got some minority of left unbalanced type and a bit more of right unbalanced type. They actually measured close follow-up for biventricular repair and univentricular repair. You can see the survival of these patients after both strategies. So if we say about surgical repair, I'd like to go through the history just briefly. So first successful repair was done in '55 by Walton and Lillyhay using their famous cross circulation, and they directly attached the AV valve to the crest of VSD. In 1960, the same surgeon Lillyhay developed two-patch, double-patch technique with a separate closure VSD and ASD. Single patch was developed by Maloney 2 years later, and he used one patch. We will go through that later for ASD and VSD. Conventional repair that we use it now was developed back in 1976 by Trussler, and single patch modification technique was developed by Nunn in 1999. So again, 3 model of that, just for easy understanding. We're going through midline sternotomy, opening right atrium, and you can see ventricular defect here. Yeah, so put a patch on the ventricular part, put a patch on the atrial part, AVSD, and we separate by these patches this common valve, and we fix the cleft on the left side. So surgical view, it's a single patch technique. So for that we have to divide bridging leaflets. And when you divide bridging leaflet, you can see the septum, the crest of the interventricular septum. And you attach your single patch to that crest. You attach separated bridging leaflets. So you can see right part, and there will be a left part. And you close AVSD with the same patch, with this part of the patch. This is coronary sinus here. Two patch technique that we use now, and it's really nice surgery. I believe it's very elegant as for me. So you close the VSD first in usual way, attaching to the crest. The patch, it can be from different material, from Dacron, from cortex, from treated pericardium. So you attach it here, but to attach second patch, you go with a separate sutures through the valve, and you have to decide what's going to the left side and what's going to the right side to balance this before you start doing the repair, because it does really matter, and the success of the repair, it depends on how well you separate the valve and how well it will be closing after your separation, because any geometrical distortion of this valve can lead to the significant regurgitation and bad result after the surgery. So it's very precise surgery at this part, and you have to think about a lot of stuff during short time of period, because you haven't got too much time to decide when patient is on bypass anesthesia. Modified single patch technique, it's when you have quite shallow VSD and you can just push the valve to the crest of the septum with a patch with the same sutures as you do for the double patch technique, but you attach the suture direct to the crest instead of to the patch. And you can see nicely the shape of VSD, of inlet VSD, is different from regular VSD. It's long and narrow. When you do echocardiogram, you can underestimate the size because you see this size and you don't really see this size. So it can be quite significant VSD if it's shot on echo in 4-chamber view. So a bit of surgical anatomy. It's always tricky to find. It's better not to find the AV node for surgeon because you've got it almost in the same place as usually, but you haven't got inlet part of the septum, and that's why AV node displaced towards the coronary sinus. I was taught simple rules to avoid that, and so far it helped me just to keep on right side of the septum and go shallow and wide in this point to avoid penetration to the left side of the septum where the AV node and branches are seated. Another strategy is PA bending. And indication for that is young age, small size of the baby, concomitant illness, and complex anatomy of the lesion. So we use usual technique as now through the midline sternotomy with the PA band. And it was interesting to find a paper from the same group, even with wide representation of North American institutions, including big names as Toronto, Philadelphia, and Cleveland. So they've got analyzed almost 500 infants from 28 institutions between 2012 and 2018 who underwent who had AVSD, and 50 of them underwent PA band, so it's 11% of consecutive patients, with a median age of 1 month and median follow-up of 2.5 years. So they analyzed what happened with these patients after PA band, and you can see that 68%, almost 2/3 of the patients, underwent biventricular repair after that. About 13% underwent univentricular repair. 12%, it's a mortality after the surgery, after the PA band, and 8% still awaiting surgery at the point of paper was published. So interesting question is AV regurgitation after PA band. It's always a question to band or not to band the pulmonary artery when you've got a regurgitation. So in 14 infants out of 50, regurgitation decreased. In 10, it's increased, and obviously it's the distribution of the regurgitation severity not changed significantly in all the group of the patients. The intended management, as I described, was to defer the ventricular decision in 23 infants. It's the half two-stage biventricular repair when you know that you will repair, but it's not the right time or the right age or right condition for the patient. So it's just postpone the repair, and univentricular repair in only in 3 infants. So you can see that among 24 infants that intended for biventricular repair, 23 achieved it, and 1 died prior to surgery. And another fact is that survival rate at 4 years after biventricular repair is the same for primary repair and for repair after the band. Well, you have to think about mortality before the repair as well. It was 12% in this series. So about complete repair, it's obviously the best choice for the patient, and it's another article from the Germany with good size group of the patients. So they've got 500 patients receiving AVSD repair, and most majority of them, it's about the same, 70%, went for a complete AVSD repair, 76 intermediate and 73 for partial. So median age of at repair was 6 months and median weight 5.6 kg. So that's the result. I have to say that it was, I mean, they divided the analysis for 2 decades. It's early era and late era. So, and obviously the result much better late era rather than early. And you've got mortality for this group of 500 patients over the 30 years time. It's quite big follow-up, and reoperation rate, it's almost the same. And the main, they analyzed risk factors for that. We'll go on the next slide for that. And you can see the immediate result is pretty good. At the moment, it's 1.6% of mortality in current era, and it was pretty high in 90s. It was about 10%. Freedom rate of reoperation from reoperation was about 85% after 25 years, and they defined risk factors for mortality is reoperation on the left AV valve. It's early surgical error, as I said, a patient age less than 3 months, and complex AVSD anatomy. The main indication for reoperation, it's not surprising, it's left AV valve regurgitation. And predictors for reoperation at discharge, at time of the operation, or first operation, is age less than 3 months, complexity of AVSD, and moderate to severe left AV valve regurgitation at discharge. Another very complex topic is single ventricle pathway for these patients, and I just want to briefly go through this paper because we can speak about that another session. And it's difficult not only because of anatomy, but because most of these patients has got 21 trisomy, and they don't really tolerate it well, Fontaine way. So, but a group from Australia with Blizzard and Konstantinov are quite optimistic about the result. So it's better than they expected. So they've got 140 patients between 76 and 2016. You can see distribution of the patients for strategies. So they even did direct Fontaine for 6 patients. And yeah, the main fact that I'd like to underline is that from all the patients of this series, about 60% progressed to Glenn shunt after initial palliation, and in this series, 85% of palliations were started at neonatal period for these babies. So you can see 60% of these patients got Glenn shunt, and about another 60% of those patients who got Glenn plus these 6 patients with primary Fontaine. So they progressed to Fontaine. Overall, you've got 25 years follow-up and about 55% of alive patients. It means 65% rate of deaths of heart transplant. That's all I'd like to share you for today. Hope you enjoyed. Any questions?
Hi, Oleg. I must congratulate you on this in-depth analysis of all the surgical options that we have in managing AVSD. I actually, really, the last article that you showed is like an eye-opener for me. I actually thought they did pretty bad, but this, I need to go through this last article that you've just shown. Thank you. Thank you for the lovely presentation.
Thank you.
Thank you, Oleg. It's Attilio here. First of all, it's nice to hear you again, and still part of our group.
Yeah.
And then take the occasion also to say hello to a couple of friends, Ange, which I think is Coventry or Stoke, and also our friends from China, which they are now part of our wider group. Thank you very much for this presentation. Very to the point actually, and very also wide in terms of problems with complete AVSDs. As Dr. Rigby said last week, there isn't a complete AVSD that is similar to the other, and if we try to classify them and put them in clusters, you know, there are some features that are common, but there are some others that specify each patient. So I think actually that I regard being able to enter into the heart in a 3-4 months 4-kilo baby and repair valves, the step where you can definitely call yourself a pediatric cardiac surgeon, because that is what is it's really important, you know, be able to go inside the heart, close the VSD, close the ASD, take all the decision and repair 1 or 2 valves and try to apply all the techniques that you have described. We have been employing actually a little bit more in the recent years the modified single patch technique, which is basically what we call the Australian technique promoted by Graham Nunn in Australia. And that is something that, you know, we have employed more and more. But I don't know if you want to make some comments about the selection of those patients, if because it's an attractive technique, but I think its selection of patients is important. So I don't know if you, Oleg, want to make a little comment on that, on your experience of what you have read.
Actually, we haven't used it in Kyiv. So we usually used it as a two-patch technique repair. But if you've got a shallow VSD when you can't put a patch properly because it's like 2-3 millimeters VSD, so I think this cohort of patients are can fit this technique very nicely. It works well, so as far as I have seen.
Yeah, thanks. We have been using actually a little bit more than the 2 or 3 millimeters, and I think actually that it's a good technique actually when you have a VSD that is not too deep, and I think actually about this, 10 millimeter, about a centimeter depth in the center is probably the highest limit, even though when I spoke with both Gus Mavroudis and with Tom Carl, which are promoting this technique, they were saying that they can do it in every case. I'm very worried to bring the reconstructed, let's say, anterior leaflet on a different plane of annulus than the mural leaflet. But we can use it actually, you know, in a variety of cases, and also when the VSD it's slightly asymmetrical, so it's more under either the superior or the inferior bridging leaflet, making the patch being a little bit asymmetrical. Hence, you can use the technique of just plastering the leaflet down onto the crest of the ventricular septum where it is shallowest, and then use a patch to fill that. And sometimes I found actually very difficult when there are loads of chordae, even in moderate size VSDs, where there are loads of chordae and thick chordae, I find difficult to slot the patch. I'm sorry, there is some background noise. Okay. So I find difficult to slot the patch underneath those chordae. Hence, I use the single patch technique. Thank you.
Thank you, Tilio, for your comment.
Oleg, Ansh here.
Hi, Ansh. Nice to meet you.
Hi, Oleg. Yeah, nice to meet you, man. Thank you, Mr. Tilio. Nice to hear from you. Hope you're recovering very well. Just a beautiful presentation, Oleg, as The thing which I wanted to ask is, one, what is your take or what is your experience about doing a PA band in very early presenting AVSDs who might present in some kind of heart failure, severe lung infections, and all those? We get quite a lot of subset. And second is, what is your take on the unbalanced AVSDs? I mean, how aggressive should we be to uh, to target a complete repair, or should we go for a 1.5 or a single ventricle?
Yeah, I got a question. Thank you, Anj. It's the most difficult part. Yeah, and very good question about the PA band, because it's difficult to separate usually, and from our experience in Audihay, that I pleased to be there for 1 year. So we had quite few patients with early presentation due to both, I think, overcirculation in pulmonary pulmonary artery, pulmonary bed, and joint infection, chest infection. And it's difficult to find a right time to put a band, because if baby is too small for repair, and it's definitely a risk factor for the mortality, for the death, and for the reoperation of the valve. It's small age and small weight. So I think it's reasonable option to put a PA band at the right time when you cover your chest infection and you stabilize patient on the ITU. And it should be a really short period of that, so you can't wait for weeks to get rid of overcirculation, because it's definitely an issue, as you can see on hemodynamic diagrams. So and when you just in the middle of the way of the chest infection, and when your pulmonary resistance is dropping, so you have to put a band just to prevent further deterioration. Because I think for these patients, the first issue is overcirculation, and after that is chest infections at joint. So just to treat a bit of infection and go for a band. The second question, it's my opinion. Second question is about single ventricle, and yeah, it's, as I said, it's obvious what to do when you've got this index, for example, or any other criteria that you use, that it's biventricular repair, and it's univentricular repair. For me, it's less than 0.2. But in this gray zone, you always have to decide, and you will get different result, I think, from patient to patient. It's not stable because it depends on many factors, and even on experience of the team, how to bring them through that difficult process if you go for risky biventricular repair. And from another side, you can choose a PA band as well, just to have some time for decision and for assessment in future, and probably it will go to one or another direction. And in this group of patients from Toronto, they've got 8 patients with left dominant.
Left dominant,
yeah, and they did go for 1.5 ventricular repair in 3 cases out of 8. And I really like the idea of 1.5 ventricular repair, and I mean, from my side, I try to push every possible patient for 1.5 rather than single ventricle.
Correct.
So it's an option for them as well, but it is difficult to decide, and it should be complex simulation, and you can't guarantee anything for these patients.
Thank you, Oleg. Thank you. Just another question to Dr. Attilio. I mean, is there anything, from your experience, from your vast experience, the surgical, any very important surgical technique to avoid the post-AVSD repair left ventricular outflow tract obstruction?
That's That's a good question, actually, because there are, as we have seen in the previous talks, actually, there are some anatomical features that can do that. One thing that I've already operated few patients is the presence in the left ventricular tract of additional chordae that go from the superior bridging leaflet to the septum. And if you identify that, you can remove that, because that actually can bring the superior bridging leaflet into the left ventricular tract. And if you have to do a reoperation, it's easy enough to do it from the aortic valve and free that. In reality, if you address well the left ventricular tract at the first operation, the problems later on with the left ventricular tract is not as relevant as used to be in the past. But there is no doubt there is a subgroup of patients actually that we require. They got a gooseneck deformity and so on and so forth. I tend actually to have a clear look actually, at the superior bridging leaflet where the left ventricular tract is. And if there is any doubt, sometimes that area is very shallow, hence, you can either put a very shallow patch, or as I was saying before, you can use a modified single patch technique. But if there is a space, just put your patch actually in a way that that area it's kept, of a good size. Pass a right angle dilator, just to have a look actually with what you're dealing with. But it's something that the one that I've operated is because there were additional chordae, actually not as such, unless there is a membrane coming up later on, but not as such actually because the repair has produced a left ventricular tract obstruction. Just a word of caution, actually, when you're using PA bands. I think actually that if you look at the big series published, you always find actually in the description of the patients, you always find of the operation that they performed, you always find in the last couple of rows a group of patients that received PA bands, either for unbalanced AVSDs or because they were clinically unstable. And I have to say actually that if judiciously position the band, I think it has got still a role in promoting growth and avoiding getting into the very small patients. I remember actually that there were, I think, a couple of large series published from one from Germany, Christian Schreiber, about the impact of weight on complete VSD repair, and the other one actually was the impact of age. So when you are presenting with a patient that is 2 months of age at about 3 kilos, I think actually our group has gone to the PA band route, because we know actually the results are not good. And in the borderline LV that we have recently a couple of patients, those are the ones actually that pose the vast majority of problems, especially when there is a complete VSD, but there is, as we were discussing with Dr. Rigby last week, a malpositioning of the papillary muscles that are either coming together or even a single papillary muscle, and those are the very complex to repair. And that is where actually I have closed the zone of opposition between superior and inferior bridging leaflet with an additional patch to enlarge that area. And if there is a papillary muscle, just split a little bit the papillary muscle and thin down the subvalvular apparatus, because sometimes the stenosis, it's really at the level of the subvalvular apparatus and put a lot of stress onto your repair. In these cases, actually, we have also, for subsequent surgery, we have started a program of melody valve implantation. So we have done one in complete AVSD after 2 repairs, and has gone well. So it's something actually that we keep now on the shelf available, because these are the cases that it's quite unpredictable how the valve will be behaving after surgery. Hence, knowing that you have a way out with a biological valve modified in such a technique that guarantees a competent valve, I think it's important.
Thank you. Thank you, Mr. Lotto. Thank you, Garima, for the beautiful organization. Thank you, team.
Thank you so much, Anshu. It was nice talking to you. I mean, hearing your voice after the longest time.
Yeah,
Lovely discussion.
yeah.
Thank you.
Yes, thank you. Thanks.
So I'd like to thank Oleg again for the wonderful talk and lovely discussion afterwards to everyone. Thank you for all your inputs, especially Mr. Lotto. Thank you for all the amazing ideas that you give, which is going to help us budding surgeons in future. Thank you.
Thank you very
Thank you
much,
very
guys.
much.
Thank you. Have a good day, everyone.
Thank you.
Have a nice day. Bye bye.
Thank you, guys. Bye.
Bye. Thank you.